So we're now going to be looking at wound care and assessment. So let's start with our skin overview. So we see there the first one is the functions of the skin. When we start to talk about the functioning of the skin, this is slightly different depending on which layer we're discussing. So you can see there in the picture those three layers. So let's have a little bit more of a look at them. So the epidermis is our top layer there, our outer layer, and it's only about 0.5 mil thick, and it's made up of several different layers. So the cells in the surface, they're constantly replaced and protecting the underlayers from dehydration and preventing the entrance of certain chemicals. So the dermis, the second layer there, it provides tensile strength and is a mechanical support and protection to the underlying muscle, bones and organs. And this differs from the epidermis as it contains mostly connective tissue with very few skin cells. The cells in this layer are called fibroblasts and they produce collagen, which is peculiar in the dermal layer. And then the very bottom, the last layer there, is the subcutaneous layer. And this is the thickest layer of the skin, providing support framework for the skin and is an attachment layer for the underlying organs and the structures. It's made up of adipose tissue, connective tissue, and blood vessels. So moving on from the skin functioning is the protection the skin provides as a covering, and it protects the body from injury or damage. This protection also relates to infection control because intact skin being the body's immediate barrier to prevent outside organisms. The skin also ensures our temperature control, and this can be through perspiration with sweat evaporating and cooling the skin. Conversely, in colder temperatures, blood vessels will constrict, and that prevents heat loss and maintains a stable body temperature. So sensation and communication is relatively easy to understand, and that's with nerve endings and receptors in our skin responding to things such as pain, touch, cold, heat. And then lastly is metabolism, with vitamin D metabolized with the help of our skin. The last slide we discussed normal skin functioning, but what about the changes when we start to get old? So we can see here a few on the screen, and some of these might include decreased sensory perception, so the older person might possibly not realize they've injured themselves. Thinner and less elastic skin, so due to reduced collagen and elastic fiber production, we can see in the picture that collagen becomes thinner, and along with less adipose tissue, the skin structure is compromised, which causes wrinkles. So for example, the skin on the back of the hand becomes thin and somewhat transparent, and this means that it can become subject to shearing, trauma and friction, which we'll discuss a little bit later. Thermoregulation, aging will decrease the ability to regulate body temperature, and this often means that older people will feel cold even on warm days. So this might tell you why you might see older men in suits on quite hot summer days. The last I mentioned there is decreased subcutaneous tissue, and this is particularly over extremities, giving joints and bones a lot of prominence. This also shows a hollowing of and deepening in the chest, axilla, and collarbone. For a very basic definition of wounds, we have the quote there on the screen, and that's an injury to the skin or underlying structures that may or may not result in a loss of skin integrity and whereby physiological function of the tissue is impaired. Although wounds may look similar and one wound might look like another, not all wounds are the same. So we'll look at some broad types of wounds a little later, but knowing the etiology or the causation of the disease or condition is really important because the treatment varies depending on the underlying disease process. So as you can see on the screen, to better understand wounds and not label them as all similar, we need to try and classify them. And we might do this based on various things such as cause of the wound, how clean it is, how severe the tissue damage is. There's four main phases of wound healing, which we can see here. The first being hemostasis, then inflammation, the third proliferation, and then lastly remodeling. So the pictures here show what the wound changes may be at the various stages, and next we'll have a look at how long they may take and how they may overlap. So as we've just seen, the first phase is hemostasis, which occurs immediately after the injury. So at this time, platelets initiate the wound healing process by releasing growth factor and drawing inflammation cells to the area of injury. Also at this time, vasoconstriction will start in order to cease bleeding capillaries. Platelets will also start to form a plug, and they stick collagen fibers to the walls of the vessel in the wound, and they also release substances to attract more platelets to seal the wound. So lastly, a clot will form, allowing the wound edges to come together, and eventually this clot will break down in a process called fibrinolysis. So then the green arch shows us the inflammatory phase, which lasts for up to 3 days. Vascular and cellular responses, they remove microbes, foreign bodies, dying tissues, and that's in preparation for wound healing. The inflammatory phase is characterized by vasodilation and increased capillary permeability, and this allows migration of leukocytes, macrophages to the wound. This increase in blood flow produces erythema, edema, heat, discomfort, and that can be such as throbbing. So when you've got a wound and it's starting to heal and it's tender, it's hot, it's uncomfortable, that's when you're in that inflammatory phase. The next phase is shown by the blue arch, and this is the proliferation phase, and this normally is between 2 and 24 days after the injury. So at this time there will be extensive growth of the epithelial cells, and they're starting to lay down fibroblasts of collagen fibers and continued growth of the blood vessels. At this time, it will form red and bumpy tissues known as granulation, and that's in the base of the wound. At this time, the wounds start to contract, and the granulated epithelial layer is very fragile, and this is important to know when you're doing your wound dressings. Lastly, we have that red arch, which is the maturation or remodeling phase. Fibronectin and collagen combine to create more granulation tissue, and eventually this fills the wound. Collagen fibers randomly start to link in a cross-hatch pattern, and they provide tensile strength to the wound. It's important to know that even after wound closure, the scar tissue will only have about 80% of that tensile strength of normal tissue. So now let's have a look at some modes of wound healing. Primary intention healing is our first picture, and this is normally a clean surgical wound without or with very little tissue loss. So the edges are normally held together by things such as sutures or staples, strips, or even glue. Under there we have the delayed primary intention healing, and this is when closure of the clean wound, like a surgical wound, is delayed by a few days, and this might be due to bacteria, microbes, or even foreign bodies. Secondary intention healing is the very bottom picture there. This is a wound that involves extensive tissue loss, and this can be pressure areas or even severe lacerations, and this often heals through a process of granulation, contraction, and epithelialization, where scarring will likely result. Skin grafting is also on there, and this is where a segment of the epidermis and the dermis is separated from a donor site and placed on a recipient site, and the skin grafts might be used to cover large open wounds or burns. Aside from things we may be aware of, such as infection, there are other complications of wound healing. The first of these on the screen there is dehiscence and evisceration. So dehiscence, as we can see, is the partial or full separation of wound layers, and patients with poor nutrition, obesity, and infection are often prone to this. So possibly following dehiscence is evisceration, and this may occur when there is a total separation of the wound layers and there is a protrusion of the underlying organs through the wound. Obviously, with the organs on the outside of the body, this would be classed as a medical emergency and would need to be treated very quickly. So next we have hypergranulation, which is the very top picture, and this is an accumulation of granulation tissue, but this extends beyond the wound surface and often delays epithelialization. So like granulation tissue, as we mentioned before, this can bleed easily and is often seen around surgical incisions. Next we have the hypertrophic scar, which is the middle picture, and here we have an overabundant deposition of collagen in a healed wound. So the wound we can see is red, raised and firm, but the scar is usually contained within the boundary of the wound. These wounds often occur when there is too much tension on a wound and can occur within 4 to 8 weeks following the injury, and they can grow rapidly for up to 6 months. And then the very last one there, the bottom picture, is the keloid scar. Now these can occur spontaneously and again from an overabundance of collagen to form firm, smooth, fibrous growth, and they result in abnormal connective tissue in response to trauma, inflammation, surgery, or burns. The biggest difference between this keloid scar and the previously mentioned hypertrophic scar is that the keloid scar heals beyond the boundary of the wound. Contractures can be seen in the very top hand picture, and this is when soft tissues such as muscles become shortened and prevent the joint moving through a normal range of movement. Contraction of the wound is a normal process of wound healing, but when the contracture is excessive, it may cause cosmetic or functional deformity, and likely this can be seen in burns, and I think that's what the top picture there is showing. So a hematoma, well, that's just our fancy nursing way of describing a bruise, and that's the middle picture there. This is a localized collection of blood underneath the tissues, often being swollen, bluish in color. A hematoma near a major artery, however, is a concern because the pressure from the expanding hematoma may cut off blood supply. Now the very bottom one there is a fistula formation, and this is the abnormal passage between two organs or even between an organ and the outside body. So for example, a surgeon would make a fistula when he inserts a PEG tube. Most fistulas, however, form from a result of poor wound healing or complications of a disease such as Crohn's disease or even in trauma or an infection. The patient can suffer from excessive fluid loss from a fistula, especially if the fistula is within the GI tract, because obviously they would lose a lot of fluid and there would be electrolyte imbalances. Previously we discussed wound healing, however, this was mainly in relation to the optimal conditions of wound healing and the perfect patient. Unfortunately, these perfect conditions are not always available, and as such there may be some factors that affect someone's wound healing. So some of these, as we can see there, so comorbidities might be a common issue with conditions such as renal failure, heart failure, stroke, or diabetes. As a side note, diabetes that is poorly controlled can lead to neuropathy, ischemia, and infection due to reduced blood supply and oxygen to wounds. A wound will increase the body's need for nutrients, protein, and energy, and as such, poor nutrition and hydration will slow down wound healing. So patients need to actually drink 6 to 8 glasses of water per day to maintain adequate blood flow and to promote wound repair and prevent dry skin, which can start to break down much easier. Medications such as anticoagulants might prevent clotting. Steroids may make the skin thinner and suppress inflammatory process in normal healing. So we've mentioned a patient's age, and this might have a reduction in blood flow and a decrease in skin elasticity. So the last one I mentioned is exudate and moisture, with high volumes of wound exudate delaying wound healing and likely increasing infection and breakdown of new tissue around the wound. Having said that, wounds do need a somewhat moist environment so that epithelial cells can slide across the wound surface. Therefore, it's important that a moisture balance is maintained, because you also don't want too dry, because a dry premature scab formation would delay epithelialization, because epithelial cells would have to migrate under the scab. So now that we have an understanding of wounds, we're going to look at assessment, starting how we might go about this process. The first step would be to ensure privacy, reduce anxiety, and this might include thinking of the exposure of our patients and making sure we only expose the minimal skin that is needed and covering up where possible. In relation to this is thinking about the temperature and the patient's comfort, as well as promoting wound healing. So we don't want to just strip someone down and make them freezing. We only want to uncover what is required at that time. It's also important to think about the lighting that we might need, and that's quite important because we need to have appropriate lighting to assess the wound color or any skin changes. We also need to educate our patient and explain what we're going to do. Along with this, we need to collect a holistic medical history, and this might include previous illness, past history of radiation, trauma, allergies, medications, a range of things, even including any problems that they might have with their skin, such as dryness or eczema or something like this. And then lastly is the physical assessment, and this includes inspection and palpation from head to toe, and we're also comparing the right side to left side to look for symmetry. So specific to wounds, there might be a few other things that we might need to consider when trying to assess the wound. We might need to accurately measure the wound, for example. We might actually do this with a paper ruler. And along with this, we might want to even send a patient for wound photography so we can stage the wound at different times and see how well the wound is progressing. We might also want to document on specific wound documentation and write down how big the wound is, exactly where it is, and we might even provide some detail regarding the wound's exudate, and we'll touch on that a little bit later on. So let's have a look at some of these assessments that we might undertake, and we're starting obviously here with the wound edges. The wound edge or the border can give us really important clues as to the type of wound that you're treating. So if we look at these pictures, the picture on the left shows a venous leg ulcer, and we can see there that it's got a sloping wound edge. And then the right picture shows an arterial ulcer with a circular kind of punched out wound. And we can also see in this picture that there's a 2 centimeter erythema that extends beyond the border margin of that wound as well. Now we move on to clinical appearance. So we can see that the left picture shows some necrotic tissue, and I think that's from an amputation site. And then the right picture shows another leg ulcer below the knee with some yellow sloughy tissue in the middle. Again, some more venous leg ulcers, with one showing, the one on the left there, showing some red granulation tissue, and the other showing some signs of cyanosis and some impaired blood supply. Here we have another arterial leg ulcer with some signs of a green infective skin, and we can see there at the bottom some white boggy macerated skin, suggesting the wound has been producing lots of exudate that we haven't appropriately dressed and mopped up when we're looking at the wound dressing. Talking of exudate, here we have 4 different types. We can see the serous exudate is the top left picture, and that is shown as a straw-like fluid. Hemoserous exudate is under this, and this has a slight stain of blood along with that straw-like exudate. Sanguinous exudate is the top right picture, and that's basically frank blood. And then the last one is the bottom right is purulent or pussy exudate. One way we may assess wounds is by categorizing them into 3 main colors. And the reason we might do this is so that we can then select the most appropriate management or goal of that wound based on the color. So based on these 3 colors, which I do agree can be fairly simplistic, but does give us a quite nice basis to base our assessment and goals around, we can see that a black wound is necrotic dead skin, which we saw before. And based on this assessment, our goal would be to debride and remove that necrosis. In the middle, we have a yellow wound, and that's likely because there is lots of slough or purulent exudate. And to ensure the wound bed can heal appropriately, our goal would be to clean that exudate, clean that slough off, and then dress afterwards. And then lastly, a red wound would indicate that the wound is healing and has some granulation tissue. And we've already mentioned that granulation tissue can be quite fragile, so our goal here would be to protect this new skin. Moving forward, we're now going to look into the types of wounds that we might see in our nursing practice. So let's start with surgical wounds. These heal through an orderly repair process and are commonly encountered within hospital settings. When we care for these wounds, it's important to observe for complications as the wound edges are brought together by sutures or staples, so there may be bleeding, dehiscence, exudate, inflammation, and hematomas. Wound dressings are applied here to protect the wound from pathogens, to absorb any exudate, and to maintain a constant wound temperature. Most wounds healed by primary intention are normally resurfaced within 2 to 3 days. A healing ridge is often palpable after 5 to 9 days after surgical incision, with a hardening beneath the skin about 1 centimeter either side of the incision. A lack of this healing ridge may end in dehiscence. And here we have a surgical wound held together with staples. We previously mentioned frail skin when talking about the older patient and the increased risk of skin tears. So most skin tears occur on back of hands and arms, are also common on lower legs, feet and head. These may occur as a result of things that we may do as nurses, such as moving patients in the bed or even removing wound dressings. Risk factors to be aware of when looking after our patients are previous skin tears, the older patient, and especially those who are dependent or cognitively impaired, as this group of patients is the group that we as nurses may be undertaking manual handling with them more often. In order to classify the type and extent of wound, we can use the STAR classification system. I won't review the entire classification, but we can see our first category there on the left is there is a skin tear, but the flap of skin is not pale or dusky and can be realigned to its normal anatomical position without much stretching. At the other end, the far right, we can see that there is a skin tear where the skin flap is completely missing. So everyone is likely very aware of burns and what they are, although because of initial assessment of burns determining the plan of care and the fact that assessments can be quite difficult, this is often important to get a specialist in the field to come and do this assessment. When we think of burns, we often think of a thermal burn, as this is the most common, with the severity depending on the temperature and the duration of that burn. Other burns, however, can include chemical burns, with the severity depending on the nature of the chemical and the duration of the contact. These burns often result in full thickness burns and may take several days to fully understand the extent of the injury. Electrical burns can be caused by alternating current, with the severity due to the voltage or the force, and the amperage, which is the strength. The burn will have a point of entry and exit, and the depth of the injury can be fairly difficult to determine. When assessing the extent of burns, there are a few ways of doing this. So the Wallace rule of nines is used for adults, where their surface area is divided into multiples of 9%. The Lund and Bowder chart, which is on the screen there, can be used for children and adults. If using for children, there might be different age-dependent burn graphs depending on the age of the child, because each child will have different body surface areas depending on their age. And if you can see there at the very bottom where it looks at the area of the head and the thigh, the difference between a 1-year-old and an adult is quite significant. So for example, a half the head for a 1-year-old accounts for 8.5% of a child's body surface area, but for an adult, it's only 3.5%. Another one to be aware of is the palmar surface, which can be used for small burns. So if using this method, you would take the palmar surface, so including the fingers and the palm of the patient, and that would account for about 1% of their body surface area, and you can use this to calculate how much of them has been burned. So with chronic wounds, in Australia more than 433,000 people suffer from chronic wounds. Pressure injuries make up a large portion of these, but are largely preventable. Pressure ulcers, pressure sores, bed sores are other commonly used terminology to describe pressure injuries that you might come across. We can see the various areas that are most prone for pressure injuries, which is mostly areas that are in contact with hard surfaces. So if we look at the patient lying on their back, their heels, sacrum, shoulders, and even the back of their head would be a risk of a pressure injury. There are various stages of pressure injuries, with it being important that we appropriately assess our patients so we can identify a pressure injury before it develops to the next stage. Here we have a stage 1 pressure injury, which presents as persistent, non-blanching redness when compared to the surrounding skin. When I say non-blanching, this means that if I press on the area, it stays red and it doesn't become pale, such as if you check your arm now by pressing down. So if you pressed on your arm with your finger, it would be white, and then when you let go, that redness would eventually come back within a couple of seconds. But with a non-blanching wound, it doesn't become pale and the color stays the same. The skin around this pressure area may be painful or itchy. It might be firm and boggy. and it might even be warmer or cooler to touch when we compare that to the surrounding skin. These are, however, quite hard to detect on dark skin tones. Remember, when you're on your first placement, when doing activities such as showers, this is a great time to also do a full skin inspection, which you might not otherwise get a chance to do so. Moving on, we can now see stage 2 pressure injury, which presents as partial thickness loss of the dermis and presents as a shallow open ulcer with a red or pink wound bed. They may also present as an intact open or ruptured blister. If a blister is found with a clear fluid present and the epidermis is clearly separated from the dermis, this is recorded as a stage 2 pressure injury. A stage 3 pressure injury represents full thickness skin loss, so subcutaneous fat may be visible, but bone, tendons or muscle are not exposed. A thick yellow slough may be present, but this does not normally obscure the depth of the tissue. There may also be undermining or tunneling, with the wound being deeper than it appears on the surface, and you'll learn a little bit more about that in your sim labs. The depth of the injury depends on where it's located anatomically. If a stage 3 injury, for example, was on the bridge of the nose or the ear, this would be quite shallow because there's not very much subcutaneous tissue there. However, if we were looking at somewhere with a lot of adipose tissue, such as the abdomen, the wound would be a lot deeper. Lastly, we have a stage 4 pressure injury, which is the most severe and represents full thickness tissue loss with exposed bone, tendon or muscle. The thick yellow slough or the black necrotic tissue may be present on some of the wound bed. Often again, there is undermining or tunneling of adjacent tissue. Like previously in stage 3, the depth of the stage 4 wound depends on the location of the body. There are, however, other categories such as a suspected deep tissue injury. These present as purple or maroon discolored intact or a blood-filled blister. Due to the damage of the underlying soft tissue, the injury is very painful. It might be firm or it might be mushy, which we refer to as boggy. It may also be warmer or cooler if we compare that to the heat of the adjacent tissue. Unstageable pressure injuries present as full thickness tissue loss, in which the base of the wound is covered by thick yellow, tan, grey, green or brown tissue. The true depth can't be determined until this slough or the eschar is removed. However, this does serve as the body's biological cover and should only be removed if absolutely necessary. Now that we know the importance of pressure injury assessment, what are the risks also? So all patients should be screened for risk using a pressure injury risk assessment tool on admission and regularly throughout their care. Examples of some of these tools are the Wardlow, the Braden and the Norton tools. These tools often address risk factors such as mobility, nutritional status, sensory impairment, level of consciousness, neurological status and even incontinence. The presence of any conditions that limit mobility to the point where a patient is unable to move independently or change position to relieve pressure means that the patient is at high risk. So when should we do these assessments? Well, they should be performed on admission and regularly throughout the stay, and this may be every 24 hours within the acute care setting, every 4 hours in a more long-term setting. Assessment should also be performed following any change in the patient's condition, such as a sudden deterioration in the health condition. And in addition, assessment should be conducted during and following any long procedures which involve reduced mobility and hardened surfaces, such as going for surgery. Moving on from pressure injuries, we have leg ulcers that are wounds that occur between the knee and the ankle that take more than 4 weeks to heal. Venous leg ulcers are the most common of these ulcers, with risk factors being age and decreased mobility, as this can lead to calf muscles being ineffective. And the reason that the calf muscles are so important is because the calf muscles contract, they push blood along the veins back up to the heart. Obesity can also cause the veins to work harder to push the blood back to the heart. Varicose veins is when one-way valve that stops blood from traveling backwards in the vein stops working, and this can lead to pooling of the blood in the lower legs and again subsequently causing a venous leg ulcer. And like we saw before, here is a picture of a venous leg ulcer, remembering the sloping edges of that wound. During our nursing assessment, particular attention needs to be paid to skin over bony prominences, such as sacral area and heels. In addition, assessments also need to focus on areas of the body where pressure, friction, and shearing is exerted during normal activities, and areas affected by equipment, footwear, and clothing. Arterial leg ulcers are less common than venous ulcers. These ulcers are a direct result of peripheral arterial disease, meaning the leg is starved of O2 and nutrients and the skin fails to function normally when an ulcer then develops. A patient with arterial disease has very cool feet and the skin may be pale or cyanosed. Pain is often worse at night for these patients when the leg is elevated in bed, and the pain is only relieved when the leg is lowered. And here we have the arterial leg ulcer that we saw before with that punched out wound edge. Diabetic foot ulcers are associated with a loss of protection sensation or neuropathy and the presence of ischemia. To treat and manage these, a multidisciplinary team is needed, and that would include the podiatrist, wound care specialist, the diabetic educator, dietitian, and the endocrinologist. Specialist dressings are often needed, such as antimicrobial dressings to prevent infection. Lastly, let's take a look at wound management. There's four main principles when managing wounds, which are the removal of non-viable tissue, control of infection, maintaining optimal moisture, and revision of the wound edge to stimulate healing. When cleaning, this should be with a neutral, non-toxic, non-irritating solution, such as normal saline or even tap water. If, however, using tap water, this does need clinical judgment. The water must be drinking water and should run for at least 15 seconds prior to use. If normal saline or tap water is not available, cooled boiled water is also appropriate. Showering is also allowed and may benefit the patient psychologically, but again, this needs to be done with clinical judgment and caution. Wound debridement that you can see on the screen is not something that we as nurses will often be directly involved in, but debridement describes any method that facilitates the removal of dead or devitalized tissue, metabolic waste, fibrin, and foreign material from a wound. Some common types of debridement are autolytic debridement, and this is where the body breaks down and removes devitalized tissues by the body's own cells and enzymes. A sharp debridement may be performed at the bedside and it involves the selective removal of dead tissue from within and around the wound to expose that healthy tissue underneath, and this is often using a sterile instrument such as scissors or scalpels. A surgical debridement is performed for removal of more extensive necrotic tissue, advancing cellulitis, or even infected bone or sepsis. So what makes an ideal dressing? So I'm not going to have a look at all of those because we've kind of hinted at some of them. We've talked about the importance of maintaining that balance between moisture and absorption. So we don't want the wound too wet, but we also don't want it too dry. We need to protect the skin, but we need to make sure that when we remove that, we need to make sure that we don't cause any damage. And when we think back to the older patient with frail skin who is prone to tears, we want to make sure that when we remove that wound dressing, that we're not going to be providing them even more wounds. No shedding of fibers, so you'll find that in hospitals now we don't use cotton wool or cotton wool balls because there's nothing worse than cleaning a wound and then having to pick out lots of cotton wool fibers there. And I think I've mentioned the bottom ones a little bit, so easy to remove because of that damage to the skin, easy to apply. There's nothing worse than trying to put a really complex, convoluted dressing on. It's easy to wear, so as well as that it's an easy dressing, it's nice on the skin, have a think about what the body's normal anatomical position is. So if you think of a wound on the knee, for example, how are you going to place that dressing? Are you going to get the patient to bend their knee, straighten their knee? It might go on fine, but what happens as soon as they bend their knee? Will it fly off? Cost effective is not really something that is going to be probably on your mind because the dressings are just going to be available to you. But think about these patients might be using these dressings for a long time and might have to buy them themselves when they go home. So don't pick the thing that is really fancy and amazing if something a little bit cheaper can do the same or as good a job as the thing that we have in the hospital. Application of the correct wound dressing will help facilitate wound healing by providing the optimal wound environment that we've been hinting at previously. They provide a moist wound environment that promotes cell migration across the wound bed. These are various types of dressings that you can see on the screen, with each of these dressings being used on a different wound that may have very different needs. So for example, a silver dressing may be used on a burn, with a foam dressing used on a wound with high levels of exudate. However, we're going to cover this a little bit more in your sim labs. I won't go over all of these now. Like I said, you will cover this in more detail in your labs, but we can see here how different wounds require specific properties from the dressings that we use. So two wounds, for example, with superficial skin loss, may actually need very different dressings depending on the amount of exudate. And this goes to show why our wound assessment is so important. Again, we have some examples of different wounds and different dressings. Aseptic technique is another thing that will be covered in the sim labs and is employed to help prevent the contamination of wounds from infection. This is achieved by ensuring that only aseptic parts of equipment and fluids come into contact with aseptic parts of the patient or the body sites during certain procedures. So ANTT, or aseptic non-touch technique, is the framework for promoting and ensuring asepsis and is adopted in the current infection control guidelines. Surgical asepsis can be seen in the right picture and is used to eliminate all microorganisms from any object in places such as operating rooms. ANTT is the left picture, with aseptic key parts of the procedure equipment must be protected at all time. These key parts, which are circled in red on the picture, must only come into contact with other aseptic key parts or key sites such as wound or insertion sites. A no-touch technique ensures that we don't touch these sites, and where we can't avoid them touching, make sure that we have on sterile gloves. Here we have a deeper description of ANTT, with the key take-home message from this is to ensure that we identify the key parts and we don't touch them. But again, we'll cover this in your sim labs.